Welcome back to The Deep Dive. Today we are opening up one of the most high-stakes, high-consequence files in all of medicine: difficult airway management. For those of you navigating that really intense final phase of your MD anesthesiology assessments, this isn't just a chapter. This is, well, it's the core competency that examiners and, frankly, your patients demand that you master.
That's exactly right. This isn't theoretical stuff. This is operational doctrine. Our objective today is to take this complex, sometimes frightening topic and structure it.
Right.
We want to build a layered, logical framework. We're aiming for the kind of precision you need, not just to tick boxes on a long answer paper, but to truly show mastery in a high-pressure viva.
Or in the operating theater.
Or, more importantly, in the operating theater.
Yeah, I really appreciate that focus on mastery. So let's unpack this right from the beginning. We need to ground ourselves in the most fundamental requirement, which is perfectly precise definitions and, understanding the gravity of the stakes. Let's start with that cornerstone definition. The one that really, it has to be the first line of your 20-mark answer.
Has to be.
What exactly is a difficult airway, and why is it so important we get this definition exactly right?
The standard, globally accepted working definition is the most precise way to frame it. A difficult airway is a condition where a conventionally trained anesthesiologist experiences difficulty with mask ventilation, tracheal intubation, or both.
Or both.
Or both. And it's crucial because that single sentence immediately establishes the two primary failure points we always have to anticipate.
The failure to oxygenate and the failure to secure the tube.
Exactly.
And the importance of mastering this. I mean, it's highlighted by multiple large-scale audits. It's stark. Why are we still so focused on airway complications when technology has advanced so much?
Because despite all our advances, new drugs, new guidelines, video laryngoscopy airway complications are still profoundly associated with high mortality rates. If you consider the data from the UK's massive fourth national audit project, NAP4, the mortality incidence related to major airway events, while rare, was still calculated at 1 per 180,000 anesthetics.
That sounds like a small number on its own.
It does, until you realize the sheer volume of cases we handle and the fact that most anesthesia-related deaths still somehow trace back to an airway issue.
That figure 1 in 180,000, it really forces you to treat every single case as potentially difficult. What were the specific failure mechanisms that NAP4 identified that we're trying to prevent?
The audit was crystal clear. The key risks were failure or, critically, a delay in securing the airway. Aspiration of gastric contents was another big one.
Okay.
And surprisingly to some, complications that arise during the extubation phase.
That last point often catches students out, doesn't it?
It really does. It emphasizes that your planning has to cover the entire perioperative course, from the pre-op assessment right through to recovery. It doesn't end when the tube is in.
So if the incidence is low, but the consequences are massive, why is this topic the perennial favorite for a DNB long answer or a complex VIVA scenario?
It's because the failure points, difficulty, delay, or total failure in securing the airway are the problems that most commonly escalate into a critical incident.
Right.
If you fail to manage an airway, the patient doesn't have time to wait. Analysis from large data sets, including closed claims reports, shows that an airway emergency increases the odds of death or hypoxic brain damage by a staggering 15-fold.
15 times. That's the real-world clinical imperative right there. It's not just a theoretical question.
Exactly. It's about demonstrating you possess the cognitive and the physical tools to prevent that 15-fold increase. And what often lands practitioners in trouble isn't some rare, bizarre pathology.
It's the fundamentals.
It's the fundamentals. Inadequate assessment, poor planning, and a lack of immediate availability of rescue equipment. Examiners want to see your capacity for integration.
Okay, so can you link the bedside tests to the algorithms?
Yes. Can you seamlessly link bedside tests, apply standardized decision algorithms like ASA or DAYS, and then demonstrate the technical knowledge of the rescue techniques? That's what they're looking.
And looking at the question patterns, they demand that breadth. It's never just list the steps of Mallampati.
Never. Absolutely. You should expect questions that require deep knowledge. Things like structuring a detailed pre-anesthetic airway assessment plan, listing all the various bedside tests and commenting on their limitations.
The limitations are key.
They are. Then there's the emerging role of ultrasound, explaining the quantitative measure of the intubation difficulty scale, or IDS, mastering the logic of the DAS guidelines, and fluently grading laryngoscopic views using Cormac-Lane. You have to deliver structured, high-detail, integrated answers.
Okay, so before we can even talk about management, we have to be using the same precise vocabulary. The Viva examiner is going to test your ability to differentiate these definitions perfectly.
Precision is the absolute foundation of a high-scoring answer. Let's start with the first potential failure point right after induction. Difficult mask ventilation, or DMV.
Right.
And you need to define this comprehensively. It is the inability to ventilate the patient adequately via a face mask due to one or more specific issues.
So it's not just one thing.
Not at all. It could be an inadequate mask seal, an excessive gas leak, and/or excessive resistance to the ingress or egress of gas.
That's a great definition because it covers the three mechanics: the leak, the seal, and the flow resistance. If you hit DMV, you've got immediate hypoxia risk.
Immediate, and you must rapidly proceed to the next strategy.
So moving on to visualization, we have difficult laryngoscopy, DL.
Yes, and this one focuses purely on the view. DL is defined as requiring multiple attempts or the use of specialized techniques or devices merely to achieve adequate visualization of the glottis.
And this is where the Cormack and Lethane system comes in. It's like the universal language for this.
It is the lingua franca, exactly. We grade DL difficulty using Cormack and Lethane, where a grade 3 or for the view, which means you can only see the epiglottis or nothing at all of the glottis, is predictive of difficulty.
Okay, so visualization is step 1. Step 2 is the mechanical challenge. Difficult intubation, DI. How do we define that, especially in a quantifiable way?
So, difficult intubation is defined as difficulty with the mechanical placement of the tube. It often requires multiple attempts or a change in your primary strategy or equipment.
And for record keeping.
For detailed record keeping, and this is key for the exam, we use the Intubation Difficulty Scale, the IDS. The IDS provides a quantitative measure based on multiple factors like number of attempts, use of alternate techniques, tube insertion difficulty.
So it's a composite score.
It is, and a score greater than 5 is often used clinically as the cutoff for defining a difficult intubation.
That scoring is so valuable for the patient's future care. But there has to be a point where difficult becomes failed. When does that happen?
Right, so failed intubation is the inability to secure the trachea after a predetermined maximal number of attempts. This is usually defined by institutional guidelines.
For example,
the Difficult Airway Society, or DAS, guidelines typically use 4 total attempts as the ceiling before you declare failure and switch decisively to a rescue strategy.
this is where we should probably introduce that crucial exam statistic. The incidence of failed intubation is wildly different depending on the patient population.
It absolutely is, and you should memorize this comparison. Failed intubation is statistically far more common in the obstetric population. We're talking around 1 in 280 to 1 in 300.
Compared to
The general surgical population, which is closer to 1 in 20 to 30. That's nearly an 8-fold increase in risk, and examiners love to ask why.
We'll definitely come back to that. Now let's address the absolute crisis point, the scenario that demands immediate, drastic intervention.
That is the cannot intubate, cannot oxygenate scenario, CICO. This is the critical, life-threatening endpoint where you have failed on every front.
So it's not just about the tube.
No. It occurs when both tracheal intubation and adequate ventilation, whether that's via face mask or a supraglottic airway device, have definitively failed.
The moment that phrase is uttered, the entire strategy has to change.
Instantly. CICO dictates an absolute immediate switch. You must abandon all peroral attempts and move straight to establishing emergency front-of-neck access.
eFONA.
Typically a surgical cricothyroidotomy. Failure to recognize the CICO state and transition rapidly is the primary cause of hypoxic catastrophe.
So just to summarize that clinical relevance, DMV is the first red light signaling immediate hypoxia risk.
Right.
DLDI tells us what equipment we need, like a video laryngoscope or a fiber optic scope.
Correct.
And CICO is the absolute non-negotiable moment we pivot to a surgical intervention to save the patient's life.
You got it. That's the framework.
Okay, now let's solidify that context by grounding ourselves in the hard data, the morbid outcomes we're all trained to prevent.
Right. The incidence of difficult intubation overall falls into the 1 to 3% range of all general anesthetics.
But the real challenge is the unanticipated difficult airway, isn't it? If we could predict them all, management would be simple.
The failure to predict is precisely why routine, systematic assessment is mandatory for every single patient. And we mentioned the startling incidence in the obstetric population at 1 in 280. We need to dig into why that risk is so high.
Is it purely anatomical, or is there a physiological component to it?
It's a combination of both. Anatomically, pregnant patients often have increased mucosal vascularity and edema in the airway. This makes the tissues more friable and swollen.
Okay.
They also face mechanical challenges, Large breasts, a short neck, which makes positioning and achieving that classic sniffing position really difficult. And then physiologically, they are pre-programmed for rapid hypoxia.
And that relates to their functional residual capacity, their FRC, doesn't it?
It does, absolutely. FRC, which is our oxygen reservoir in the lungs, is significantly decreased in pregnancy because of the elevated diaphragm. This drastically shortens the safe apnea time.
By how much?
Well, in a non-pregnant, healthy patient, you might have 5, maybe 6 minutes before severe desaturation. In a pregnant patient, that time can be halved. It makes rapid failed attempts catastrophic.
Let's move to the consequences of failure. Hypoxia is immediate, but what happens downstream from that?
Hypoxia is the primary insult, and it can lead to brain injury or cardiac arrest. But closely following that is aspiration.
Right.
Loss of protective reflexes during induction or during prolonged, messy attempts at intubation makes the patient highly susceptible to inhaling gastric contents. And that's a major cause of morbidity, leading to aspiration pneumonitis.
And then there's the physical damage inflicted during repeated forceful attempts.
Airway trauma. It's incredibly common. The most frequently cited persisting injury is dental trauma, which occurs at an incidence of about 1 in 4,500.
And what increases that risk?
The risk is amplified by pre-existing poor dentition, difficult airway anatomy, and, crucially, poor technique or excessive force when inserting or leveraging the laryngoscope.
Beyond the teeth, what about the soft tissues? What injuries should we be guarding against?
We have to remember the risk to the laryngeal and tracheal structures, things like laryngeal damage, vocal cord injuries, granuloma formation, and in chronic cases, tracheal stenosis.
Even the rescue devices aren't harmless.
Not at all. Excessive cuff pressure from a supraglottic airway device can cause pharyngeal necrosis. We also have to be alert to severe early complications like hemorrhage or a catastrophic mediastinal perforation from aggressive stylet use.
And if the failure proceeds rapidly, we face the highest consequence of all.
Cardiac arrest. This usually results from severe hypoxemia, but it can also occur from acute hemodynamic collapse. You have to remember, induction agents and positive pressure ventilation can critically worsen hemodynamics in a sick or hypovolemic patient.
How does that happen?
The sudden increase in intrathoracic pressure from the positive pressure ventilation can severely impair venous return to the heart, and that can lead to cardiac arrest.
Finally, let's touch on the elephant in the room for any high-risk procedure, the medical legal consequences.
Airway failure is a massive medical legal liability. Difficult airway management leading to cardiorespiratory arrest and subsequent death or brain injury. It forms the basis of many indemnity claims.
So documentation is key.
Documentation must be meticulous. You must prove you followed standard guidelines, planned appropriately, and communicated the risk using quantitative measures like that IDS score we mentioned.
Okay, let's transition to proactive defense. The ability to predict difficulty is probably the most high-yield skill, both clinically and for the exam.
It is.
We need to structure these predictors into manageable subsets, starting with the ability to mask ventilate the patient after induction.
Absolutely. For predicting difficult mask ventilation, or DMV, the mnemonic devices are the key to quick recall in the exam hall. We use the robust mnemonic bones, or sometimes you'll see obese.
Let's break down that bones mnemonic, making sure we include the specific criteria.
Let's do it. B is for beard. This seems obvious, but facial hair prevents you from creating that airtight seal you need for effective mask ventilation.
Right.
O is for obesity. Specifically, a BMI greater than 30 is a strong independent predictor of DMV. It's linked to increased airway soft tissue and that reduced FRC we talked about.
Okay.
N is for no teeth or edentulous patients. The lack of underlying structure makes the face mask collapse onto the soft tissues, so you can't get a good seal.
So you should leave dentures in, if possible.
Leave dentures in until after induction for this very reason. E is for elderly. The age often cited is greater than 55 or 57 years. This is linked to decreased tissue elasticity and reduced muscle tone, leading to more upper airway collapsibility.
And finally, S.
S is for snoring or confirmed OSA. Obstructive sleep apnea. This is a huge red flag. It indicates chronic upper airway collapse and difficulty maintaining patency, especially under the depressive effects of induction agents.
Are there any other DMV predictors that we should mention in a really comprehensive answer?
Yes. You should add limited jaw protrusion, which also predicts intubation difficulty. Also, increased neck circumference, especially over 43 centimeters, or a history of prior neck radiation. These all contribute to DMV risk due to tissue rigidity or mass effect.
Okay, now let's move to the physical assessments designed to predict difficult laryngoscopy and intubation, DI. Where do we start?
That begins with the classic Mallampati classification, as modified by Samsoon and Young. Students often forget the details of the exam technique here.
What's the correct way to do it?
The patient must be sitting upright, open their mouth wide, and maximally protrude the tongue, and crucially, without phonation.
Because phonation artificially elevates the soft palate.
Exactly. It gives you a falsely reassuring view.
Let's review those 4 grades. Examiners expect perfection here.
They do. So
Yeah.
grade F, you see everything. Soft palate, fosses, the entire uvula, and the pillars. This suggests an easy view. Grade a second. You see the soft palate, fosses, and only the base or a portion of the uvula. Grade third, only the soft palate and the very base of the uvula are seen. This strongly predicts difficulty.
And grade 4.
Grade fourth, only the hard palate is visible. This predicts a very high degree of difficulty.
Then we assess the structural measurements, starting with the simplest physical restriction.
That's mouth opening, or the inter-incisor distance. You need at least 3 centimeters, which is roughly 2 adult finger breaths, to comfortably insert and maneuver the laryngoscope blade.
And less than 3 centimeters suggests?
It suggests severe restriction. It immediately pushes you toward thinking about fiber optic or video-assisted techniques.
Next, we look at that crucial submandibular space needed to push the tongue forward.
That's the thyromental distance, or TMD. It's measured from the thyroid notch to the lower border of the chin. Normal is greater than 6.5 centimeters, about 4 finger breaths.
And a short TMD.
Less than 6.5 or less than 6 in some texts is highly predictive of difficulty.
And why is that?
Because a short TMD suggests the larynx is anatomically anterior, and there just isn't enough space to accommodate both the tongue and the laryngoscope blade at the same time.
And there's also a related measurement that incorporates neck extension.
That is the sternomental distance, or SMD. It's measured from the sternal notch up to the mentum, with the neck fully extended and the mouth closed. Less than 12 centimeters is associated with DI. It's a measure of how effectively the patient can get into that sniffing position.
Speaking of position, that leads us right to neck flexibility.
Neck mobility is essential. Limited cervical mobility, especially restricted extension at the atlanto-occipital joint, dramatically interferes with aligning the 3 axes, the oral, pharyngeal, and laryngeal. That's the prerequisite for a good view.
And what about the structures that are right there interacting with the blade? The teeth and jaw.
You're looking for physical abnormalities. Long upper incisors, or buck teeth, a prominent overbite, a recessed lower jaw, retrognathia. A key functional test is assessing the ability to protrude the mandible.
So can the patient get their lower teeth in front of their upper teeth?
Exactly. If they can't extend the lower incisors beyond the upper ones, it suggests restricted TMJ function, which is necessary for aligning those axes.
And the high specificity test related to that is the upper lip bite test.
The URBT is functionally superior to just looking at static anatomy. You ask the patient to bite their upper lip with their lower incisors. The inability to do so is associated with difficult laryngoscopy. Its high specificity means if it's positive, you should strongly suspect difficulty.
Let's pause before we get to combining these. If an examiner asks for the single most reliable predictor out of this entire list, what's the answer?
Unquestionably, the single most reliable predictor is a history of difficult airway.
Simple as that.
Simple as that. If a patient was difficult before, you must assume they will be difficult again, maybe even more so. Reviewing previous anesthetic records is a mandatory step in the preoperative workup.
And let's just add the final anatomical factors, especially relevant in larger or obese patients.
A short, thick neck is highly predictive. A neck circumference greater than 43 centimeters, or 17 inches, should raise an immediate flag. And modern studies are showing the value of imaging.
Like ultrasound.
Yes, ultrasound-guided measurement of pretracheal adipose thickness, if it's greater than 2.5 centimeters at the level of the vocal cords, is being cited as an independent predictor. It's often more accurate than just a simple BMI measurement alone.
Now, on to the limitations. If we have all these tests, why do we still miss difficult airways?
Because the limitations of individual tests are profound. And this is where students often lose marks. You must state this clearly. No single test predicts 100% accurately.
Take Mallampati, for example.
Perfect example. If you use it alone, it has low sensitivity. It misses many true difficult airways. And it has a low positive predictive value. A high grade often leads to an easy intubation anyway.
So you're over-predicting and under-predicting at the same time.
Exactly. You will incorrectly categorize up to half of your patients if you rely on Mallampati alone.
So we combine them. What are the multivariate scores the examiner expects us to know, and what's the benefit?
Combining multiple predictors drastically improves the predictive power. You should know the names and the intent behind scores like the Wilson Risk Sum score.
What does that include?
It combines parameters like weight, head and neck movement, jaw movement, receding mandible, and buck teeth. There's also the El-Ganzouri Risk Index, which incorporates 7 factors: mouth opening, TMD, Mallampati, neck movement, prognathism, weight, and previous history.
The benefit, then, is that by requiring multiple risks be present, we improve the specificity and the overall predictive value.
Correct. The key takeaway for the exam is that you need a comprehensive assessment, and you have to acknowledge the paradox. Even when your combined prediction score suggests an easy airway, you must still maintain preparedness.
Because surprises can crop up.
Because surprises can and do crop up when you least expect them.
Okay, this section is about turning that academic knowledge into a real, deployable clinical process. A systematic approach to the pre-anesthetic evaluation.
Exactly. Your long answer paper needs to show that structured approach.
And we always begin with a directed patient history, right?
Always. You start by focusing on key risk areas, any previous anesthetic difficulties, recent weight gain, trauma history, or symptoms that suggest pathology like stridor or hoarseness. Then you immediately transition into the physical examination.
Starting with just looking.
Just looking. Visual inspection for the obvious red flags. Facial deformities, a short, thick neck, receding mandible, a large goiter, burns, scars.
In a planned elective case, we have time for that full battery of bedside tests. But in an emergency or a trauma situation, time is precious.
In that chaos, you must have a rapid cognitive checklist. The Lemon assessment is mandatory knowledge for emergency and trauma scenarios because it quickly filters for the highest risks.
Let's break down Lemon.
L is for look externally for massive edema, trauma, obesity. E is evaluate the 3-3-2 rule.
3 finger breaths, mouth opening, 3 higher mental distance, and 2 between the thyroid notch and floor of mouth.
Perfect. M is Mallampati, if possible. O is for obstruction. Is there stridor, a foreign body, blood, swelling? And N is neck mobility, especially cervical spine restriction.
And we perform those individual bedside airway tests as part of this process. We've talked about their limitations when they're alone, but let's reiterate their strength when combined.
Their strength is in synergy. If you find a Mallampati the fifth combined with a TMD of 5 centimeters and an inability to do the ULBT, your likelihood of difficulty skyrockets.
Okay.
Also remember that tests like Mallampati can be made more specific if you perform them with the head in full craniocervical extension, which mimics the actual laryngoscopy position.
Let's focus specifically on the challenges of airway assessment in emergency situations. When you're dealing with trauma or a critical bleed, what changes? What do we have to prioritize?
The priority shifts entirely to patency and oxygenation. First, can the patient talk? If they can talk, the airway is patent.
Simple as that.
Simple as that. Second, you always assume cervical spine instability. This mandates manual inline stabilization, or MILS, which effectively limits your access and your view.
And
Third, be prepared for distorted anatomy maxillofacial trauma, expanding hematomas, or burns that cause rapid airway edema. These scenarios often require you to bypass standard assessment and move straight to advanced techniques like awake fiber optic or even rapid surgical access.
All right, moving from prediction to action. This section is all about the cognitive and physical steps we take before the patient ever loses consciousness.
The ethos has to be. Anticipation and planning are paramount. Any unanticipated difficult airway significantly increases the risk of severe morbidity.
So the team needs to be on the same page.
For elective cases where difficulty is flagged, the anesthesia and surgical teams must discuss alternate plans beforehand. Who is going to manage the front of neck access and when?
And if that difficulty is anticipated, the gold standard strategy is often to delay induction entirely.
Yes. If major difficulty is predicted, the safest route is to secure the airway prior to induction. The patient remains awake, preserving their spontaneous ventilation and their protective reflexes. This guides us toward techniques like awake fiber optic intubation.
Now, let's talk about positioning. It's so foundational to success. We need to detail the standard sniffing position versus the position for high-risk patients.
The standard position is the sniffing position, mild cervical flexion with the lano-occipital extension. But in the morbidly obese, this is completely inadequate. You must use the ramped position.
Or the HELLP position.
Or, as it's often referred to by the mnemonic, the HELLP position, head elevated laryngoscopy position.
Tell us about the HELLP position specifically. Why does it work so much better for obese patients?
The HELLP position involves elevating the upper body and head until the patient's external auditory meatus, the ear canal, aligns horizontally with their sternum. This counteracts the mass effect of the chest and the redundant pharyngeal tissue. It provides a superior alignment of the laryngeal axis, and studies have consistently shown it improves the view compared to just using a head ring.
And what about when we can't move the neck at all, like in a trauma with Mills?
In trauma, Mills means minimizing neck movement. This severely restricts achieving that optimal alignment. In this scenario, we rely heavily on alternative devices,
Specifically videolaryngoscopy.
particularly videolaryngoscopy, VL, as it requires less force and less head positioning to achieve a view.
Equipment preparation moves beyond just the standard tray. We need the big guns ready.
The difficult airway cart must not just be present. It must be checked, fully stocked, and immediately accessible.
What's on that cart?
The inventory has to include a videolaryngoscope with various blades, a range of supraglottic airway devices like the ProSeal LMA or the ILMA, the fiber optic bronchoscope checked and operational, and the crucial crisis management equipment, the cryptothyrotomy set, and the capability for jet ventilation.
Next, buying time. The role of pre-oxygenation. How do we maximize that crucial safe apnea time?
Pre-oxygenation is absolutely essential. The goal is denitrogenation. We achieve this by giving 100% oxygen via a tightly fitting face mask for either 3 to 5 minutes of normal breathing, or, if time is critical,
4 big breaths.
4 maximal vital capacity breaths within 30 seconds. And the specific target you must state for the exam is achieving an end-tidal oxygen fraction, or ETO2, of 90% or higher.
If you don't hit 90%, you haven't done it properly.
You haven't pre-oxygenated effectively.
Correct.
And finally, integrating this all into a plan.
We have to formulate backup plans based on standardized algorithms like ASA or DAS. This means establishing the cognitive roadmap before induction. If I fail with DL, what is plan B? For example, VL. If plan B fails, what's plan C? ASAD. And when do I call CICO and move to the surgical plan?
Okay, this is the critical section, the moment of truth. Let's start with the fundamental principles of airway management, the rules that must never be broken. 5 principles guide all difficult airway management. 1. Anticipate difficulty and prepare. 2. Maximize oxygenation always, pre-oxygenation head position. 3. Maintain spontaneous breathing for as long as possible in known difficult airways.
Number 4.
Call for expert help early. Don't wait for the saturation monitor to start alarming. And 5. Limit your attempts and know precisely when to shift strategies or resort to surgical access.
Let's trace the stepwise approach that aligns with major guidelines. If we anticipate difficulty, what's the fork in the road?
The initial decision is critical. Awake intubation versus intubation after induction. If the patient has a significant aspiration risk, we often combine induction with a rapid sequence approach. But you make that decision knowing you have a rescue plan ready.
If we induce the patient and that initial laryngoscopy attempt fails, what's the immediate instinctual response?
Stop. The first immediate step is to revert to mask ventilation and verify if oxygenation is maintained. Do not persist if the saturation is dropping.
And you have to limit the attempts.
Critically, guidelines mandate severely limiting the number of laryngoscopy attempts. The DAS guideline often limits practitioners to a maximal total of 4 attempts, including 2 from the most experienced operator, before you declare failure.
If mask ventilation is adequate, so we can oxygenate the patient, but intubation is failing, what's our next rescue path?
We escalate to the intermediate rescue device. Insert a supraglottic airway device, a SAD. This secures the ventilation pathway, buys us time, and provides a potential conduit for further attempts, like using an ILMA to pass a scope.
If that fails, mask ventilation fails and cessate ventilation fails, we are on the CSCO pathway.
But first, let's discuss the alternatives to direct laryngoscopy.
Direct laryngoscopy, or DL, is increasingly being supplemented by technology, starting with videolaryngoscopy.
What are the primary strengths of VL, and when do we favor it?
VL is excellent in trauma or Mills cases because it requires less manipulation of the neck. It provides a highly magnified, clear view on a screen, which is great for teaching and for confirming tube placement.
And its effectiveness. It dramatically reduces the incidence of poor views. Studies show grade 3 or worse views are reduced to around 5%. However, a vital caveat, in emergency situations, blood, secretions, or vomitus can completely obscure the lens.
Next, the supraglottic airway devices. Beyond general rescue, are there predictors of difficult SA placement we must recognize?
Yes, even SADs can fail. We use the mnemonic RDS to remember these predictors. R for restricted mouth opening, O for obstructed upper airway like a tumor, D for disrupted upper airway from trauma, and S for stiff lungs from poor compliance, like in severe asthma or ARDS.
And finally, the true gold standard for predictable difficulty and anatomical distortion.
Fiber optic intubation, or FOI, remains the gold standard for securing the airway and predicted difficulty, particularly when anatomical distortion from tumors or burns or severely restricted mouth opening is present. It allows for controlled, precise placement.
Often done while the patient is awake.
Exactly.
Let's dedicate some time to awake intubation, as this requires deep technical knowledge for a long answer question. What are the definitive indications?
Indications include any anticipated difficult airway, especially if the patient can't tolerate muscle relaxation. Also, a significant aspiration risk where spontaneous ventilation must be maintained. And of course, severely restricted mouth opening, like with TMJ ankylosis or maxillofacial trauma.
And what are the physiological advantages that make that added complexity worthwhile?
The primary advantage is the preservation of spontaneous ventilation and pharyngeal tone, which ensures airway patency throughout the procedure. The patient maintains their protective reflexes, which guards against aspiration.
And the anatomy?
The anatomy is often more favorable. The larynx remains in a more posterior and easily accessible position than it does after induction and muscle relaxation.
The preparation for awake FOI is meticulous. What are the key pharmacologic components you need to mention?
You must list 3 key preparation steps. First, an antisialagogue is non-negotiable to clear secretions and provide good visualization. Glycopyrrolate is the preferred agent because it's potent but non-sedative.
Okay, second.
Second, meticulous topical anesthesia is required. Typically, lignocaine 2% applied to the nasal passages, the vocal cords, and the trachea. Finally, titrated light sedation.
Good light.
Midazolam or fentanyl to achieve a Ramsey scale of 2 to 3. The patient is cooperative but calm, while critically maintaining spontaneous breathing. You never sedate them so deeply that you abolish their protective reflexes.
We've established the road to failure. Now let's focus entirely on the recognition and resolution of the CICO crisis.
Recognition is the first hurdle. The failed airway is reached when you have exhausted your maximal intubation attempts, let's say 4 attempts, and you cannot ventilate effectively via Facemask, and you cannot ventilate effectively through supraglottic airway device, that is CICO.
Once CICO is recognized, what are the immediate management principles?
The moment of recognition has to trigger an internal alarm and an external call. Immediate call for senior help. Next, you must execute the cognitive pivot. You abandon all further attempts at per-oral access. The principle is to secure oxygenation, and the only remaining route is surgical.
That decisive, non-negotiable action is the mandate for emergency front-of-neck access, eFONA.
Yes. Surgical cricothyroidotomy, or transtracheal jet ventilation, is mandated immediately upon recognizing CICO. This requires a skill set that must be practiced and maintained even by anesthesiologists. You have to move to the neck. It's the patient's last chance.
Are there patients in whom even surgical access will be difficult? We need to prepare for that.
We do. Just as we predict difficult intubation, we have to predict a difficult surgical airway. The mnemonic BANG helps us remember these high-risk factors.
Let's hear it.
B is for bleeding tendency or severe coagulopathy. A is for an agitated patient, making landmark identification impossible. N is for neck scarring or flexion deformity, making the cricothyroid membrane hard to find. And G is for a growth or vascular abnormality in the region, like a massive goiter or radiation damage.
The central theme here is the importance of early decision-making. Time is truly lethal in this scenario.
Every second wasted on a 5th laryngoscopy attempt or a 3rd SAD insertion when the patient is desaturating is compounding the risk of permanent brain injury. The delay in transitioning to a surgical airway is consistently shown to be the most common human factor error in CICO scenarios. That surgical airway must be established within seconds.
The tube is in, the patient is stable, the crisis is averted, but the job is not over. Our management discussion has to extend into the post-airway phase.
Absolutely. Documentation is essential both for clinical continuity and for medical legal protection. You have to meticulously record every detail. The grade of laryngoscopy view, the number of attempts, the devices used, any difficulty.
And using the IDS score here is a good idea.
Using the IDS score is excellent because it quantitatively communicates the total difficulty to the ICU team or the next anesthesia provider. It acts as a measurable alert.
That leads directly to a handover. What needs to be communicated during that transfer of care?
Clear communication is vital. You have to explicitly inform the recovery team or the subsequent caregiver about the airway status. If the intubation was difficult or if there's any ongoing risk of airway deterioration like laryngeal edema, this has to be highlighted as a priority.
And for the patient's long-term safety, we have to counsel them.
Patient counseling is mandatory. You must inform the patient about the episode and strongly recommend they get a medical alert identifier or a card detailing the difficult intubation. This crucial step ensures that in any future emergency, other providers are immediately aware of their high-risk status.
Finally, extubation. We noted that this phase can be equally or even more dangerous than induction.
Extubation considerations are paramount. You have to risk stratify the patient before extubation using guidelines like those from DAS. Extubation often carries a higher risk because the airway may have deteriorated from swelling, and if reintubation fails, the patient is already sedated, making rescue difficult.
What are the key factors associated with increased extubation risk?
The core factors are a known difficult airway history, any evidence of airway deterioration like edema or bleeding, restricted physical access to the patient's airway, pre-existing obesity or OSA, and a high aspiration risk.
So if any of those are present.
If any of those are present, you must have an appropriate plan, such as leaving an airway exchange catheter, an AEC, in place to guarantee reaccess should extubation fail.
Let's pivot back fully to the assessment structure. To score highly, you need to anticipate the examiner's line of questioning.
Be prepared for these comprehensive, frequently asked, long-answer questions. They test your clinical and academic integration.
For example,
Things like provide a detailed definition of the difficult airway, its risk stratification, and the comprehensive management of extubation risk. Or list and comment extensively on the bedside tests used to predict difficult intubation, discussing their predictive value.
they'll want to see the algorithms.
Always. Discuss the full steps of the ASA or DAS algorithm for unanticipated difficult intubation. And outline the technique, preparation, and indications for awake fiber optic intubation.
Now for the common pitfalls, the student mistakes that cost crucial marks.
The Mallampati trap. Mistaking the score alone as a sufficient or highly predictive test. You must always comment on its low sensitivity.
What else?
Confusing definitions. Failing to clearly distinguish between difficult laryngoscopy visualization and difficult intubation tube placement. Also, losing sight of oxygenation. Persisting too long with attempts when the sats are falling.
And in the discussion of await intubation.
Poor preparation. Discussing it without detailing the necessity of both topicalization and the non-sedative anti-sialagogue, glycopyrrolate.
So what are the examiner-approved safe answers? The phrases that show mastery.
Always emphasize anticipation, structured preparation, and calling for senior help early. That shows professional judgment.
Okay.
Stress the principle of maintaining spontaneous ventilation until the airway is secured, especially in known difficult airways. Highlight the technical necessities. Achieving 90% ETO2 pre-oxygenation and using the ramped position in the obese, and the definitive action statement for the crisis.
The immediate decision upon CICO is emergency front of neck access.
That's the one. It signals decisiveness and knowledge of the final safety net.
A picture is worth 1,000 words, especially in an exam. You have to be ready to sketch and label key diagrams.
For the assessment section, you need to master the airway assessment diagrams. The Mallampati classification, clearly labeling the structures in each of the 4 grades, and the Cormack and Lethane grading, illustrating the laryngoscopic view.
And to show superior knowledge of laryngoscopic views.
Beyond the classic grades, make sure you highlight the poor view grades, 3 and 4. Furthermore, mention the POGO score percentage of glottic opening as a valuable objective measure.
The management hinges on flowcharts. We need to be able to reproduce those quickly and accurately.
You must be able to sketch the basic framework of the ASA or DAS flowchart for unanticipated difficult intubation. Your diagram must clearly illustrate the decision tree, the initial choice, the moment of failure, the rescue pathway with the SAD, and that final CICO endpoint.
Finally, how do we synthesize all this into a high-scoring 20-mark answer structure?
Structure's paramount. Start with a crisp introduction and precise numbered definitions. Organize the body of your answer with clear, bolded headings. Integrate diagrams where they're relevant, and conclude with a high-yield summary that ties the principles together.
We've covered the entire cognitive architecture of difficult airway management. For our listener preparing for that final assessment, let's distill this into the 15 take-home exam points for immediate retention.
This is your rapid checklist. 1. Difficult airway means difficulty in intubation, ventilation, or both. 2. DMV is predicted by bones. 3. DI is predicted by Mallampati III, TMD less than 6.5 centimeters, limited neck extension, and history.
History is the most reliable predictor.
4, yes, history is the most reliable predictor. 5, no single test is sufficient. You need multivariable assessment. 6, anticipation and planning are the core principles. 7, pre-oxygenation to 90% ATO2 is mandatory. 8, the ramp position is crucial for the morbidly obese. 9, awake fiber optic intubation is the gold standard for anticipated DI. 10, glycopyrrolate is the preferred antisialagogue for awake intubation.
Okay, 5 more.
11, laryngoscopy attempts must be strictly limited. 12, S of Ds are the essential intermediate rescue step. 13, CICO requires immediate emergency front of neck access. 14, extubation carries significant risk. Planning is vital. And 15, airway failure remains the leading cause of anesthesia-related morbidity and mortality.
That's a powerhouse summary. To conclude, if you're racking up that 20-mark essay, what's the model paragraph that demonstrates total integration and confidence?
It has to stress adherence to structured action. The cornerstone of managing the difficult airway is anticipation, thorough preoperative assessment using standardized multivariable metrics, and, critically, strict adherence to established decision algorithms, such as the ASA or DAS pathways.
Go on.
By maintaining preparedness, ensuring optimal positioning like ALP, maximizing pre-oxygenation, and employing controlled strategies like awake intubation when indicated, we significantly minimize the risk of failure. Finally, the ability to rapidly recognize the CICO state and make the prompt, decisive action to secure the airway via emergency front-of-neck access is the final, non-negotiable safety net required to safeguard the patient against catastrophic hypoxic brain injury or death.
Mastery achieved. You've got the knowledge. Now go apply those principles flawlessly.
Remember, every plan must have a rescue plan, and the airway always comes first.
That concludes this deep dive. We hope this has prepared you thoroughly for the challenges ahead, both in the exam hall and in the operating theater.